Welcome to A&P Live Studio. I am your host. As a registered nurse and anatomy and physiology instructor for advanced healthcare professionals, I'm glad you're joining me. Today, we're going to examine the pathophysiology of deep vein thrombosis, a condition that often starts silently, but, as we'll see, can have truly life-threatening consequences. So here's our roadmap. We'll start with a patient's story to ground us in a real-world clinical scenario. Then, we'll look at the body's normal balancing act and the three key factors that can throw it off. From there, we'll follow a clot's path, see how we diagnose and treat it, and then zoom out for the big picture. All right, let's begin where it matters most, in the clinic. Understanding the patient's experience is really the key to understanding the underlying pathology. I'd like you to meet Eleanor Vance. She's 72, and she's just 3 days out from a total hip replacement. She's calling for help because her right calf has suddenly become swollen and painful. It's also red and feels warm. Now, for any clinician, these are the absolute classic textbook signs of a potential deep vein thrombosis. So this brings us to our central question. What exactly is going on at the vascular and cellular level to cause these symptoms? To really get a handle on what's going wrong, we first have to review what's supposed to go right. So let's move on and take a look at the body's really elegant system for controlling bleeding, a process we call hemostasis. You can think of hemostasis as this incredibly fine-tuned balancing act. On one hand, the body has to be ready to form a clot instantly to prevent you from bleeding out from an injury. But on the other hand, it has to have powerful brakes to stop that clot from growing out of control or forming when it's not needed. This whole dance is choreographed by a complex series of reactions we call the coagulation cascade. This cascade happens in 3 main phases. It all starts with initiation. Some kind of vessel injury exposes a trigger called tissue factor. That kicks off the amplification phase, where just a tiny chemical signal sets off this massive chain reaction. It's like a single spark igniting a wildfire. And finally, propagation, where all that activity results in a strong, stable fibrin mesh that becomes the backbone of the clot. Okay, so now that we have a feel for the normal cascade, we can really explore what goes wrong in DVT, and the framework for understanding this was actually figured out way back in the 19th century, but is just as relevant today. This is Virchow's triad. It tells us that a thrombus, or a clot, usually forms because of one or more of these 3 things: venous stasis, which is just slow blood flow, endothelial injury, meaning damage to the inner lining of the vein, and hypercoagulability, which is a state where the blood is just more prone to clotting. Now, in our patient, Mrs. Vance, we're about to see a perfect storm where all 3 are in play. First, let's talk about venous stasis. Because of her surgery, Mrs. Vance has been immobile. This has slowed down the blood flow in her legs, allowing it to pool, especially in the little pockets behind her venous valves. This stagnant, low-oxygen environment is a huge red flag for the body. It basically puts the veins lining on high alert and starts calling clotting factors to the area. Second, endothelial injury. That hip replacement surgery, while great for her joint, inevitably causes some trauma to the surrounding blood vessels, including the femoral vein. This direct damage to the vein's inner lining exposes that tissue factor we talked about, which directly kicks the coagulation cascade into gear. And third, we have hypercoagulability. This is a systemic issue, meaning it affects the whole body. The delicate balance of hemostasis is tipped way in favor of clotting. It's like the pro-clotting side of the scale is being weighed down, creating a pro-thrombotic environment everywhere. Several things are contributing to this state in Mrs. Vance. Major surgery itself creates a massive inflammatory response that promotes clotting. Her age is also an independent risk factor. And here's where it gets really interesting on a molecular level. There could be a genetic piece. Up to 5% of Caucasians carry a mutation called factor V Leiden. This makes a key clotting factor resistant to being broken down, tipping those scales even further towards forming a clot. So, Virchow's triad has created this perfect storm in Mrs. Vance's leg, and a clot has formed. Let's now connect that pathophysiology to the symptoms she's having, and, more importantly, the potential dangers. So, that thrombus is acting like a dam in the vein. It's obstructing blood flow, which is what causes that classic swelling. The pain, the redness, the warmth, those are all signs of the intense inflammatory response that the clot is triggering. But here is the most crucial takeaway. About half of all people with a DVT have no symptoms whatsoever. It can be a completely silent condition, which is what makes it so dangerous. And that leads us to the number one danger of a DVT. The biggest risk isn't actually in the leg at all, it's in the lungs. If a piece of that clot breaks off, it becomes what we call an embolus. That embolus can travel up through the heart and get lodged in the arteries of the lungs. This is a pulmonary embolus, and it is a true medical emergency that can absolutely be fatal. So, given that incredibly high risk, you can see why fast and accurate diagnosis followed by immediate treatment is so critical. Let's look at how we confirm a DVT and what we do about it. We usually take a two-step approach. We often start with a blood test called a D-dimer. It's highly sensitive, which means a negative result is great. It pretty much rules out a DVT. But it's not very specific. Other things can make it go up. So the gold standard, the test that actually confirms the diagnosis, is a duplex ultrasound. It lets us literally see the clot in the vein. Now, treatment is all about anticoagulation, and this field has undergone a major revolution. For years, we used drugs like warfarin that were tricky to manage. But today's frontline therapy is a class of drugs called direct oral anticoagulants, or DOACs. They are a game changer. They work by targeting and inhibiting a very specific enzyme in the cascade called factor XA. This precise targeting means patients can take a fixed oral dose, they don't need constant blood monitoring, and their risk of major bleeding is lower. It's a huge leap forward. All right, to wrap things up, let's pull all of this information together and see how a DVT really fits into the context of the entire body. A DVT is not just a disease of a single vein. It's a systemic problem that really touches on multiple body systems. It originates in the cardiovascular system, of course, but its deadliest complication hits the respiratory system. The lymphatic system gets involved too, because poor venous flow makes the swelling or edema even worse. And, as we saw with Mrs. Vance, it's often the muscular and skeletal systems that kick things off, with immobility being that initial trigger. So let's just trace that entire narrative one last time. We start with the body's normal, delicate balance of hemostasis. Virchow's triad comes along and disrupts it, causing a pathological clot. That clot can manifest with clinical signs like swelling and pain, but it also carries that silent risk of a pulmonary embolism. And finally, we intervene with these targeted drugs, like DOACs, to try and restore that delicate balance. You know, as our understanding of molecular biology and genetics continues to grow, the future of DVT management might not just be about controlling risk factors, but about identifying and correcting these subtle imbalances in the coagulation cascade before a clot even has a chance to form. Stay pathocurious, and I'll see you next episode. This presentation is for educational purposes only and is not intended as medical advice, diagnosis, or a substitute for professional healthcare decisions.